Here we go. All right. Great. So I'm going to share my screen and get started. I'm giving the introduction lecture. It's one of my favorite lectures to give, and I think an important time to be talking about this field. So let me share my screen. Share slideshow from beginning. Okay. Okay. So before we get started, so today's talk is an introduction to women's mental health, women's reproductive mental health. Next week, Dr. Easton will be talking about anxiety and OCD in the perinatal period. Dr. Challam will be presenting on August 20th on bipolar disorder in the perinatal period. And then finally, Dr. Shanique Richards will talk about coping with fertility-related grief and loss, a relational approach. So we're very excited about the lecture series. Also, many of you who signed up for this lecture series have been added to our listserv. We have rounds pretty much every week at this time throughout the year, and it's a wonderful opportunity to continue learning and join the conversation. And everyone is welcome anytime. Once a month, we do have a team meeting at this time, but we usually announce that ahead of time when we're able to keep that in mind. And we'll try to be on top of, Nicole is very on top of putting out a schedule so you know what to expect. Okay, I have no disclosures. My learning objectives today are to be able to describe current hypotheses regarding how sex hormones may contribute to psychiatric disorders, understand key clinical features and course of psychiatric disorders specific to the female life cycle, and to understand the basic principles of a relational ethics approach to the perinatal psychiatric consultation. I will get into what that means a little bit later. But first, I'm going to start with some descriptions or quotes. You'll see. Anyway, I'm going to start here and we'll go from there. So this is a quote from the dean of the Harvard Medical School in 1855, who said, "Granting that women in exceptional cases may have all the courage, tact, ability, pecuniary means, education, and patience necessary to fit persons for the cares and responsibilities of professional life, they still are and must be subject to the periodical infirmity of their sex, which for the time and in every case, however unattended by physical suffering, unfits them for any responsible effort of mind, and in many cases of body also. It is not to women as physicians we would object, but to their often infirmity, during which neither life nor limbs submitted to them would be as safe as at other times." Let that one sit for a moment. And then this, I like this, I found this on Twitter at some point, when it was Twitter. Times when women are likely to be told they have a mental disorder: when disclosing abuse or violence, in family court, when making a complaint, when whistleblowing, whilst grieving for someone, during perimenopause or menopause, when in poverty, when homeless, when engaging in casual sex or dating, when successful or ambitious, when they become angry or assertive, when worrying about something, when raising concerns about health. Times women are told they don't have a mental disorder. It's just the baby blues. It's just the change. She's just on her period. When she's pregnant or parenting and struggling with substance use. When she's in an IPV relationship. Nothing will get better until she comes to her senses and leaves. And then finally, a very recent quote talking about depression and pregnancy. Is that because this underlying mental illness that we're trying to control for, one we don't test for when there's no objective testing, is just more prevalent in women? Or are women just naturally experiencing their emotions more intensely? And those are gifts. They are not symptoms of a disease. This was during the FDA panel on the safety of SSRIs in pregnancy. And here are some headlines about how many women are being put in prison for having substance use issues while pregnant or parenting, or for losing their pregnancies, and how abortion restrictions are being used by perpetrators in intimate partner violence relationships. So the reason I'm starting here and why I'm going to end on sort of when I start talking about sort of general principles of perinatal care, I think it's really particularly important in this moment in time to really understand things through the medical ethics lens, because we are all in the
Oh,
position
you want to recall it 2 minutes? Thought Quinn being be
uh,
to your way.
ethical decisions about treatment in pregnancy, before pregnancy. And actually, I think this generally, these principles obviously apply across the board. But the basic principles that we all learn in terms of medical ethics and medical ethical decision making are beneficence, so first do no harm, non-maleficence, don't act with malice, autonomy, and embedded in the autonomy of the patient is the concept of informed consent, truth-telling, and confidentiality. Autonomy is the principle that makes these a necessary part of medical ethics, and then finally justice. But given the examples I just put up there, how are medical ethics applied to a population for whom, because they are pregnant or might one day become pregnant, the principle of autonomy is in question? We'll just let that sit out there as we go through the rest of this talk, which I promise most of it won't be as political, but it's all political. So first, let me start. Why should there be a specialty in women's mental health? Why does our program exist? So one answer is that depressive and anxiety disorders are disproportionately more common in women of childbearing and child-rearing age. And I'll go through some of those statistics. Historically, most studies on treatments for psychiatric disorders have excluded female subjects, including in animal models, because of the hormonal changes. So, for example, in some animal studies, often the studies are only done in male animals because the estrous cycle of the female makes interpreting the results confusing. But that's bad for patients and bad for science. And the development of brexanolone, for example, for postpartum depression is a good example of why ignoring the hormones and the experiences of half the population is bad for science. Sex and gender are critical determinants of mental health and mental illness. And when I'm talking about sex and gender, I do, in my slides, I do use a lot of gendered terms. That's both because it's sometimes more convenient, and also because a lot of what we're talking about is really on that border between biological sex and gender in ways that are complicated. But if I can do better in terms of being inclusive language, please feel free to let me know. Psychiatric disorders are developmental and need to be understood and treated in the context of the life cycle.
Person you're trying to reach.
Sorry. There's also been an exponential growth in knowledge in the field that is difficult for general psychiatrists and mental health practitioners to keep up with, including knowledge that is important for pregnant and postpartum patients. And finally, our field as a whole, I'd say psychiatry and to a much lesser extent psychology and social work and the other mental health fields have been failing women, birthing people, and families. So I'll start talking about epidemiology. We'll talk about some of the theories of etiologies of sex differences and psychiatric disorders. Then we'll talk about perinatal mental health and maternal mortality. And I'll end with a brief overview of sort of an idealized perinatal psychiatric consultation. So what do we know about sex differences in rates of psychiatric disorders? So the lifetime risk of major depression and dysthymia are about twice as high for women as for men. So women are twice as likely as men to experience a major depressive episode or have a diagnosis of dysthymia in their lifetime. The prevalence rates for most anxiety disorders, including panic disorder, agoraphobia, specific phobia, generalized anxiety, and PTSD, post-traumatic stress disorder, are 2 to 3 times higher in women. And there's some interesting exceptions, such as OCD and social phobia, where the rates are about equal. The rates of severe mental illness are similar between men and women, but there are differences in diagnoses, age of onset, and the course. So in bipolar disorder, the type bipolar 1 disorder, the lifetime risk is about equal in men and women, about 1%. Type 2, bipolar 2, is diagnosed more commonly in women than men, although it is unclear if that is a reflection of who presents for treatment with hypomanic episodes and how they get diagnosed. Women tend to have more mixed episodes and rapid cycling. They also tend to present with a later age of onset for the first manic episode and have more depressive episodes. In schizophrenia, the lifetime prevalence, again, is about the same in men and women, but women tend to have a later age of onset. So the median or mean, I'm sure, is between 25 and 35, whereas for men, it's about 18, with a bimodal distribution. So there is a second bump of new diagnoses of psychotic disorders later in life, in the 40s. For eating disorders in clinical samples, anorexia nervosa diagnoses, 95% of people diagnosed are female, and for bulimia, it's 80%. However, in anonymous survey data, men also report subclinical binge eating and other eating disorder behaviors at comparable frequency to men. So I think this is important to understand that there is, of course, it's of course important to track psychiatric diagnoses and ask the questions about why there might be these differences, while also recognizing that who presents to treatment or who actually gets a diagnosis is in part determined by cultural and socioeconomic factors, right? For substance use disorders, men are 2 to 4 times more likely to have a diagnosis of a substance use abuse or dependency. However, women with psychiatric illness are more vulnerable. There's a higher sort of change in the risk for women with psychiatric illness with comorbidities compared to men with psychiatric comorbidities. And there are changing patterns over time with opiate use disorders where more women have been affected by opiate use disorders recently, unfortunately, contributing to overdoses. In personality disorders, women are far more likely than men to be diagnosed with borderline or histrionic personality spectrum personality disorders. And men are much more likely than women to be diagnosed with antisocial, narcissistic, or obsessive compulsive personality disorders. Now, again, with personality disorders, there's a lot of controversy in the field, right? And is this reflective of differences at an ideological level, or again, biases in sort of how similar pathologies are present through the lens of gender and culture and societal expectations, and how it's interpreted by someone giving a diagnosis, or who even presents for treatment versus ends up in the prison system. So, which is already getting into some of the questions about etiology. Why are there these differences in rates and expression of psychiatric disorders in men and women? And again, I'm going to talk about some of the, taking on its face this idea that there are these differences in psychiatric diagnoses, even if there are some differences in who presents and what diagnoses are given. I always think it's helpful to think about things through the biopsychosocial lens. And by biological factors, we're talking about genetics, illnesses, substances, nutrition, various environmental exposures, among other things. Social factors include family, friends, resources, and safety. And psychological factors include trauma, early losses, and attachment or coping styles. Different people may interpret these factors differently, but I literally still, when I see a new patient, I'm going through the biopsychosocial model in my head, and I find it very helpful. So when we're talking about women in depression, for example, why are women twice as likely compared to men to have a major depressive episode in their lifetime? It's impossible to separate out some of these issues. So there are significant differences in the rates and effects of trauma. If you look at a population level, the rates of physical and sexual abuse in childhood are different for boys and girls, and the impacts of different types of trauma may have different impacts later on in development. There's a lot of writing about gender roles and developmental stress on girls compared to boys, and which types of stressors are more harmful in a developmental model, as well as discrimination. Some people theorize that the multiple roles and caregiving responsibilities of women may put them at higher risk from a stress diathesis model. Socioeconomic status is impossible to really separate out in terms of risk. People with lower resources are at higher risk of depression and other psychiatric disorders. And if you just looked at a plain population level, women tend to have lower SES than men. Reproductive events. So we'll talk more about the impact of the hormonal. I'm going to go into some depth about the hormonal theories.
Thank you. No problem.
As well as some of the stressors that are psychosocial stressors that go along with these. And so we'll talk a lot about the biological factors, hormone differences, and then I'm not getting into this in this talk today, but there is a large and really growing and important literature about the immune system and its contribution to psychiatric disorders or manifestation of psychiatric symptoms. And we know there are differences in immune systems between men and women, likely impacted by hormones and other factors and other types of stress. So important to keep in mind, as I was discussing, so in terms of sexual assault, 82% of all juvenile victims, of all children who are sexually assaulted, are female, and 90% of adult rape victims are female. And again, this is really not to, I don't want at all to be seen as minimizing the impact of physical and sexual violence on men or on anyone of any gender. But I want to point out that when we're looking at population level, there are these major differences, which could account for some of what we see in the clinical practice. Females aged 16 to 19 are 4 times more likely than the general population to be victims of rape, attempted rape, or sexual assault, and that's a critical developmental time. Also a time a lot of mental disorders tend to start to manifest. Nationwide, 81% of women and 43% of men report experiencing some form of sexual harassment or assault in their lifetime. In terms of reproductive events related to psychiatric disorders, we'll talk about the menstrual cycle, infertility, pregnancy, the postpartum period, the menopausal transition, and any hormonal therapies. You can think about any of these transitional moments. So adding hormones, having hormones drop, or taking away hormones. Any transition seems to be a period of risk for psychiatric symptoms, if not disorders. Although there are differences in who might be more vulnerable. So we do see that there is this higher incidence of depression, and that difference in between women and men, or boys and girls, starts at puberty and then becomes less marked post-menopause. So during the reproductive years is really when we see the differences between boys and girls, men and women, in expression of depressive disorders. Studies that have looked at suicidal behavior do find some correlation in group-based studies, that suicidal behavior in women appears to be more common in low estrogen states. So that sort of points the direction that at least some changes in hormone levels might be associated in some people with suicidal behavior. We've known for a long time that psychosis and psychiatric admissions are significantly elevated immediately after childbirth. And importantly, there seems to be a relationship between people who experience premenstrual dysphoric disorder or severe premenstrual psychiatric symptoms, perinatal depression, and perimenopausal depression. So someone who has significant psychiatric symptoms premenstrually may be at higher risk of a perinatal mood and anxiety disorder, and also may be at higher risk for experiencing depression or anxiety in the transition to menopause. So it's not that every individual is sensitive to hormones from a behavioral or psychiatric point of view, but there seems to be a subset of individuals who are particularly hormone sensitive. And for these individuals, we can think about the expression of their, their risk as sort of hormonally mediated or hormone sensitive mood disorders. So again, not everyone is equally affected by hormones, but there are people who probably are much more affected than others. And so there's a cohort of people who we think are at higher risk during these hormonal periods of hormonal transition, which also are almost always associated with a lot of psychosocial transition as well. So this is just the data that sort of reflects this. So you see this split in diagnoses of depression that starts to separate between boys and girls around puberty. You see that 10 to 14 time point is when there's really the separation. And then in this study, it's interesting, there's sort of an increase in rates in women right around when the average age of menopause, which could reflect a perimenopausal bump, but the numbers on this study are not quite where they need to be to really say that for sure. This is a paper that actually grouped a number of different studies that looked at the risk for suicide attempt and correlating it with the menstrual cycle. And what they found is that the periods of time where people seem to be at higher risk for suicide attempts is in the very early follicular phase or very late luteal phase. So either during the time estrogen is dropping or immediately after estrogen has dropped to its lowest level in the menstrual cycle. Can go into those if anyone has any questions about them. This is a classic study from Edinburgh where they looked at rates of first psychiatric hospitalization compared to pregnancy in primiparous women. So women with no children who have their first child, the risk for psychiatric hospitalization is fourfold higher. And increased risk continues for about the first 3 months and never quite goes down to baseline. I always make the joke that those of you who are parents may have some theories about why after childbirth, the rate never quite goes down to the baseline before having children. This is a much more recent study that shows has a very similar finding that for all hospitalizations for psychosis are there's a significant increase in risk in the first 3 months postpartum. And this solid line reflects people who have had no prior psychiatric diagnosis. So it seems that the postpartum period is a high risk time for both recurrence of severe psychiatric illness as well as for the emergence of new onset psychiatric illness. So we think it's probably a hormonal thing, right? Or at least in part a hormonal thing. But why might that be? So just a little reminder, squint your eyes, don't focus too hard on this for the steroid biosynthetic pathway. I put this up here just to make a couple points. One is that all of the sex hormones, actually all of the hormones, are cholesterol derivatives. They are all related to each other, and there are catalysts that affect the balance of these hormones in the body. That can be impacted by a number of different things, such as nutritional status and certain substances or drugs or illness or just genetics. Also, there are a number of different progesterone derivatives. And so there can be a different, each individual may have a different profile of how much of each of these hormonal derivatives they have, and then on the receptor side, there can be a vast amount of difference in the receptor profiles and distributions. We won't get into this in too much detail, but a little bit of a reminder about the menstrual cycle. So the first part of the menstrual cycle is called the follicular phase. It's when A follicle is developing. The follicle is where the egg cells sit. The follicle develops. During that phase, there is relatively low and stable estrogen predominant hormonal milieu. And this tends to be a time for most people who have premenstrual symptoms of a relative well-being. Mid-cycle, there's a spike of estrogen, which then triggers a surge of LH, which is what triggers ovulation, and which is the exit of the egg cell from the follicle. That follicle becomes a corpus luteum, which starts to secrete progesterone. So right after ovulation, so before ovulation, you have a big swing of estrogen, and then immediately following ovulation, you have this surge of progesterone. And then if that egg is not fertilized, the corpus luteum cyst degrades, and both progesterone and estrogen drop precipitously, which is what then triggers menstruation. So there's this cycle of changing hormonal milieu. And while for most people this causes, minor symptoms, for some people it can be very disruptive. And we think that it's the transition in hormones rather than absolute levels that are problematic. So why might hormonal transitions or certain predominance of certain hormone derivatives be problematic for some individuals? Well, sex hormones are not just sex hormones. They are neurosteroids. They are neurotransmitters, or they affect neurotransmitters, I should say, profoundly. There are multiple subtypes of estrogen receptor distributed throughout the central nervous system and the gut. And they have profound impacts on some of the main neurotransmitter pathways. So as an example, estrogen, estradiol increases serotonin synthesis and decreases serotonin reuptake. So if you have a surge of estrogen, the net effect is to make serotonin more available in the synapses of serotonergic neurons. And that affects both the brain and the gut. Progesterone, in contrast, actually decreases serotonin synthesis and increases MAO, so it clears serotonin out of the synapse faster. So if you have high estrogen level, progesterone level, it's going to clear the serotonin faster from the synapse, so serotonin becomes less available. That's only one way that sort of a big level that that hormonal changes can impact significantly serotonergic synapses, and there are multiple other impacts on other transmission pathways. Notably, GABA transmission is impacted significantly by brexanolone, which is the synthetic derivative of progesterone. I'm forgetting the name of it in the progesterone pathway, but it does in fact GABAergic tone, which is in part why we think it's helpful for postpartum depression. So I'm putting this there, you obviously don't have to remember it, but if you think about sex hormones having a profound impact on every neurotransmission pathway, and each individual is going to have a different sensitivity to these multiple hormonal transitions, as well as the relative concentrations of different hormones and the distribution of the synapses. So I've talked about most of this. They also have multiple effects on different systems. I don't want to spend too much time on this. So then when we think about perinatal mental health, there's a lot going on. And one of the things to really understand what's going on is the hormonal transition. So this is sort of a cartoon version, but when you're looking at what happens to hormone levels, sex hormone levels during pregnancy, what you see is that estrogen and progesterone levels go to about 50 times what they are in the peak of the menstrual cycle. And then immediately after the placenta is delivered at birth, they essentially go down to postmenopausal levels within 48 hours. So it is a huge hormonal transition. And if you have someone who has a sensitivity to psychiatric symptoms with hormonal transitions, you can begin to see why this hormonal drop alone for some individuals may precipitate symptoms. And again, I'm focusing a lot in this talk on the hormonal impact and some of the biological impacts because I think it's poorly understood. And as you will hear in other lectures, there's a lot more going on than just the hormones. Okay, I want to spend a moment to talk about maternal mortality and perinatal mental health, because when we're talking about making treatment decisions for psychiatric disorders in pregnancy, it's really important to understand the stakes and not to minimize them. I know everyone here, you know, I'm speaking to the converted, right? Like I understand that everyone is here because they have an understanding that this is really important. But in this time when I think not just the what should be done to treat mental health problems in the perinatal individual is coming into question, but even as you saw in the beginning, the very idea that there can be perinatal mental health problems or perinatal psychiatric disorders is being called into question. It's more important than ever to really understand the science and the reality and the risks and what's at stake so that you feel confident as you're making treatment decisions together with your patients, that what you are doing is balancing the right things, right? The risks of untreated illness and the risks of whatever treatments we are recommending or prescribing. So the first thing is to remember is that mental illness is a source of tremendous suffering for our patients, and they deserve the care we can offer regardless of their reproductive status.
Yeah.
So I say this because even, you know, even I sometimes am really wish that I didn't have to prescribe medications in pregnancy. I really prefer not to. And I love it when I don't, you know, when I'm able to get someone through a healthy pregnancy with their well-being intact and we don't have to use pharmaceuticals or, you know, what other interventions. And we can't minimize that suffering. And that suffering alone is important, regardless of what the impact is on the pregnancy or the future child. And so really centering our patients and understanding that it's a source of pain and it's part of our duty of care to provide relief to that suffering is really important. I tell this story a lot, forgive me for everyone who's heard this many times from me, but it's sort of emblematic. Long time ago, I treated a woman during her second pregnancy. She had a terrible depression. And then, you know, we treated her depression and she got better. And she told me that in her first pregnancy, she'd been in a car accident and had a broken femur. And it was a bad break. She needed surgery and went through this whole thing during that pregnancy, which is really tough. But she said after she recovered from her depression in her second pregnancy, she said, you know, when I broke my leg, no one said to me, oh, we can't give you any pain medicine because that might cause some problems for the pregnancy or for the baby. And you know, I'll never forget, she said, I would take that broken leg any day of the week over getting this depressed again. And it was one of those like, oh yeah, that's real. These are real, this is real pain and suffering. Maternal and parental well-being is critical for children's physical, cognitive, and emotional development. And treating maternal well-being during and after pregnancy is an essential part of maintaining their ability to support their children's development and health. And this gets into the idea of fetal origins of health and disease. And some of you here may be able to explain it better than I can, but essentially that the roots of many developmental or the expression of many chronic conditions and the impact of stress and other psychiatric disorders starts in pregnancy, starts during fetal period, when the impact of a variety of environmental exposures as well as severe stress, including the stress of untreated mental illness, can have effects on the expression of certain genetic pathways through epigenetics. And again, some of you may understand this far better than I do. I don't want to overplay this, but it is true that we do see an impact of untreated psychiatric disorders on the future child. I am not saying that treating depression with antidepressants reverses this. I want to be clear about that. And I am saying that treating depression will help the parent support their child no matter what their status is. Pregnancy and childbearing is a stress test of the individual, family, societal, and healthcare systems, one that we are in this country, I think, not meeting well. And mental health disorders are a major contributor to adverse maternal morbidity and mortality outcomes, and most of these are preventable. If you haven't read anything about it, I encourage you to look at this article by our former fellow, the wonderful Dr. Ali Sachs, and to point to the research of Aurélie Attan, who's a wonderful researcher here at Columbia, who really revived the concept of matrescence, which is the idea that childbearing is a developmental passage where a woman transitions through preconception, pregnancy, and birth, surrogacy, or adoption to the postnatal period and beyond. The scope of the changes encompass multiple domains: biopsychosocial, political, spiritual, and can be likened to the developmental push of adolescence. So the idea that parenthood, motherhood is a developmental process. This is a much more in-depth look at what happens to hormone levels during pregnancy, a little bit more, less of a cartoon, but essentially saying the same thing in terms of the shifting hormonal milieu during pregnancy and then during lactation, where there are these profound changes in hormone levels of not just estrogen and progesterone, but also prolactin, cortisol, and oxytocin, among others. Over the course of this experience. And those hormones alone can have impacts on certain areas of brain. And this is a nice study looking at the multiple studies linking hormones, brain, and behavior over the perinatal period. And I like the point that this group makes, which suggests these investigations should actively contribute to the ongoing rebranding of motherhood, portraying it as a phase of constant brain adaptations, thereby dispelling outdated notions of the maternal brain being dysfunctional or inadequate. That there are, in fact, a lot of responses of the brain to the changing hormonal milieu that actually are very adaptive. And it is an opportunity for growth and new pathways. And so you can think of, there's a lot of maybe pejorative expressions about mommy brain, and we can joke about that, but it also is a reality that a brain in transition, where there's a lot of plasticity and a lot of changes, maybe prioritizing different things than what are valued in our work life, for example. This is a slide I'm really glad I never saw while I was pregnant with my daughters. But the idea being that the health of the mother is actually critical in terms of the health of the future children, and in the case of girls, grandchildren. So stress and distress, including that experienced in psychiatric disorders, can have long-lasting impact on the development of the future child. Although I also want to make the point, which I say to my patients all the time, remember, babies are very resilient. And for 99.99% of human history, babies have been born into much more adverse conditions than even a very stressed parent in Manhattan in 2025. So keep in mind that this is all relative, and that if you have depression, it's not necessarily the case that you are harming your child. I also want to point out that attachment is not an abstract concept in the perinatal period. It is very, very concrete, right? And so on the left, you have this lovely dyad of mother and baby, and that communication. And if you haven't, I put the screenshot of Beatrice Beebe's book, where it's a picture book of the mother-infant interaction picture book. And this is just a lovely example, little gif of this mother-child, the dance of the mom and child and their interactions there. On the right is a shot from the still face experiment, which I'm not going to torture you with in this lecture, but if you've never encountered it, you should Google it and watch this video. It's only 2 minutes. It's a little painful, but in that video, you see that an otherwise well-attached dyad, the baby who's I think about 6-7 months at this point, when mom doesn't respond to her for just 2 minutes, she completely becomes distressed and overwhelmed to the point of losing postural stability. So just a brief period of not having that level of engagement is an incredibly stressful experience for the child. And for 2 minutes, there's separation and repair, and that is obviously something that babies are very adapted to be able to cope with. And in fact, part of what learning is and development is, separation and repair, or not getting needs met and then getting needs met. However, if you think about a parent who, because of psychiatric illness, because of trauma, because of other stressors, housing instability, food instability, inconsistent caregiving, is not able to provide that a secure attachment base, you can see in a consistent way, you can see how that could be very harmful over time. Mental health disorders are a major contributor to adverse maternal morbidity and mortality outcomes, and most of these are preventable. So I'm on the New York City Maternal Mortality Review Committee, and at some other point, we can talk about what this looks like, what these deaths look like, because we review the cases in great detail. Every case gets about an hour discussion in great detail. Our maternal mortality rate, and this is up through 2024, or actually this is up through 2022, far outstrips that of any of our peer high resource countries. Let me come back to that. Even in New York, this is New York state data up through 2018, there are huge disparities in maternal mortality rates. So I wanted to put up New York's data just in case there's a temptation to think, well, that's, not to dunk on Mississippi, that's a Mississippi problem. It is not. Black women in New York State are at higher risk of death than Black women across the country, and 4 or 5 times at higher, or actually up to 8 times more likely to die than white women in New York. So these disparities are due to systematic racism and other risks that go along with it, which is a whole other lecture in itself. But a lot of these disparities are also mediated through mental health and well-being. And how chronic stress and discrimination manifest over time. So if you look at, this is data up through 2019, if you look at deaths due to mental health conditions, that's suicide and overdose deaths, over 20% of pregnancy-related mortality, so deaths that are deemed to be related to pregnancy, over 20% are mental health related deaths. And if you compare that to other causes of obstetric death, you can see that it really is very significant. I understand, of course, I'm combining two different causes of death here to make the point, but it is comparable and more common. Each of the mental health causes of death is comparable to any of the obstetric causes of death. But until pretty recently, they weren't necessarily considered as part of pregnancy-related deaths and weren't given the attention that, fortunately, they have gotten in recent times, and hopefully we will be able to give in the future. There is data coming out, despite some attempts not to see it, that increasing restrictions on reproductive freedom are disproportionately impact those already vulnerable to mental health problems, particularly in minoritized populations. So we see that through risks, not only the direct obstetric causes like risks of death in a miscarriage, but also people who are imprisoned due to pregnancy loss, or who are in situations where they are either being coerced to terminate a pregnancy or coerced not to terminate a pregnancy. All right. So I'm going to switch gears and get back to medical ethics as well as to the clinical approach to the perinatal patient. And I'm going to tell the story of the reason I'm actually in this field to begin with, which is a case I saw in my PGY2 year on the inpatient unit of a woman who was brought in to the psychiatric hospital, to NISB, floridly manic, and she had a positive pregnancy test in the emergency room. So I was a PGY2 resident, and I was working with an attending who was a relatively new attending at the time, and we went on up to date and we looked and said, okay, well, what's safe to give her in pregnancy? And Haldol was the only thing that looked like it was safe to give in pregnancy. So we were giving her Haldol and giving her Haldol, and she was stiff and manic, but still really, really manic and really sick. And we were stuck. We didn't know what to do. What else can we give her? It's too risky. And fortunately for me, Meg Spinelli, who later became such an important mentor for me and continues to be, was able to do a consultation with us. And I still remember, she said it very nicely, but essentially said, she was like, okay, the Haldol isn't working. You need to stop treating your own anxiety and actually treat the patient. And it was one of those aha moments, like, right, this is a patient who's very, very ill. And in fact, so ill that she couldn't even decide, she didn't have the capacity to decide whether she even wanted to be pregnant at that moment in time. And it was our responsibility to help her get better. And even if there were some risks of our treatments, because she was very ill and stuck in the hospital. So we ended up going through the risks and benefits of lithium and treated her with lithium. And guess what? She got better. So getting back to sort of the principles of medical ethics, right? Beneficence, non-maleficence, autonomy, which informs informed consent, truth-telling, confidentiality, and the principle of justice. If you think about that case, right, I think we got stuck in a medical ethics decision-making frame, right? First do no harm. Uh-oh, we're stuck there. What if we give something that has potential harm to the fetus? That seems to violate medical ethics right from the get-go, right? And so each of the principles of medical ethics can get you stuck in a situation with the pregnant individual, including, justice for whom, whose autonomy, and non-maleficence. So what has made much more sense to me treating perinatal patients, and I think as an approach that can be more broad as well, is the concept of relational ethics, which is related to the ethics of care, which was developed from the feminist movement from the 1970s and carries forward and treats ethical decision-making, individuals in ethical decision-making, not as isolated entities, but embedded within the network of social, cultural, and economic relationships that shape health and well-being. And in this context, the interests of the pregnant person and fetus are not separate, but intrinsically intertwined, right? If you consider the maternal fetal dyad as one system, and you're trying to balance risks and benefits as you would with any illness, right? So with cancer, we give chemotherapy, even though it causes some harms, because it is so important to treat the illness. And the principles that go along with relational ethics include mutual respect and engagement. And so that incorporates understanding what we're each bringing to the table and the power dynamic inherent there, right? So in the case of the manic patient whose ability to give informed consent was disrupted right from the beginning, she was floridly manic and psychotic. Our attempts to not cause harm, to first do no harm, was actually not being respectful of, reestablishing her own autonomy and identity. And so, and it's our duty to use our medical expertise for the benefit of our patients and the dyads that are our patients. and in turn to respect the individual and their experience. And that's where we get into embodied knowledge, right? So when I'm seeing a perinatal patient, I have knowledge of all the data and statistics and what the literature says about the risks of psychiatric illness and the risks of medications, but I'm not sitting in their body and I don't know what their experience is. And so I have to have some respect for what they're bringing to the table, what it's like to have depression, what they know because of that, right? And sometimes this comes out when I say, like, you can feel it in your body when you're depressed. That's not a healthy environment for you, for your other kids, for the pregnancy. We have to have an awareness of the environment, including the exposures that we're giving, as well as the environment of our patients in the different systems in which they're embedded. Uncertainty, that we can't pretend to know the outcomes, and we have to tolerate a certain degree of uncertainty, the idea that there's no risk-free decisions. And then finally, justice, that we are informed by a justice approach. Okay, so I'll stop preaching about this, but I do think it's important to really think about your framework as you're seeing a perinatal patient, and think about your patient as the dyad, and having respect for the pregnant person, that they are also doing the best that they can to make the best decisions for themselves, for their pregnancy, for their family, and really having respect for that, for autonomy in that sense. So when we're going through a perinatal psychiatric consultation, I try to do it in two parts. I'm going to sort of skip through this a little bit because we can get into it. When I try to see patients twice when I'm doing a consultation, sometimes if it's very simple, I don't always, but we do a lot of information gathering, really trying to do a thorough diagnostic interview. We want to know really what their experience of their psychiatric illness is, what their experience of depression, anxiety, bipolar illness is, including what the risks are, what their experiences have been, what treatments they've had, what's worked, what hasn't worked, what have they tried, what haven't they tried, do they get suicidal? When they're depressed, do they use alcohol more? Do they have a hard time taking care of themselves or adhering to recommendations? We do get some parallel history, we do a literature review, and a case discussion for complex cases, and then we see them again together with a partner or another family member if possible, or if it's recommended. We review the diagnostic impressions with the patient and relevant points of their treatment history, and then we go through what we call the risk analysis. So we provide some education about the risks of what we know in general about untreated illness, psychiatric illness in pregnancy, and the risks that we are concerned about specifically for the patient in front of us. We review what are the known and unknown risks of the medications or other therapeutic options that are available for those illnesses. And we engage in shared decision making to try to find the right plan for that patient. We do know that untreated mental illness in mom is associated with poor healthcare and treatment adherence, higher rates of preeclampsia. Pregnant people who have depression and other psychiatric disorders have a much higher, harder time quitting smoking. They have higher rates of tobacco and other substance use, including alcohol, and a much harder time quitting during pregnancy. So a good example is smoking rates at this point in the general population are between 10 and 15%. For the depressed population, it's between 20 and 30%. And in pregnancy in the general population, it goes down to between 5 and 8%. But for the depressed population, it goes down to maybe 20%. So people with depression have higher rates of even that's just tobacco use and a much harder time quitting. People with psychiatric disorders have higher rates of poor nutrition, whether due to food instability or their psychiatric illness impacting their ability to get adequate nutrition, loss of interpersonal and financial resources, having untreated anxiety and depression in pregnancy is the biggest risk factor for postpartum anxiety and depression. We'll go to these. And for the child, we know that people with untreated psychiatric disorders, the babies tend to have lower birth weight, higher rates of preterm delivery, lower APGAR scores, smaller head circumference, cognitive delays, although that's, these are subtle and only in big group differences, difficulty engaging in social object interactions, less positive and more negative affect, increased cortisol and catecholamine levels at birth, increased rates of NICU admissions and dysregulation of the HPA axis. So I will end here on my sort of basic principles of making perinatal, treating perinatal psychiatric disorders. The first is know what you're treating. We all have patients who have a little bit of this, a little bit of that. They have maybe a lot of trauma in their history. We've given them a diagnosis of generalized anxiety or bipolar disorder, or they came to us with a diagnosis of something like bipolar disorder, and they're on a bunch of medications that seem to be working. Pregnancy or contemplating pregnancy is really a time period where you need to reassess what you think you know about the patient and get the story so that you are clear, both in order to make good treatment decisions, but as well as to make sure that you're documenting appropriately what you're treating. If you're going to treat with the medication, you should know what it's being used for. Second principle is that there are no risk-free decisions. When there's illness, there's risk. We have to make the best decisions we can, understanding that there's risks to not treating as well as risks to treating. We use a shared decision-making framework with respect for patient preferences and values, and we use our expertise to help balance both risks of illness and the risks of treatment for the patient and with the patient. We avoid polypharmacy, so multiple medications when it's possible. The best medication is usually the one that works for the patient at the lowest effective dose, with an emphasis on the effective dose. I see a lot of people with subtherapeutic levels. We want to maximize non-therapeutic supports such as nutrition, exercise, financial, occupational, housing, and social supports. We want to evaluate and reevaluate psychotherapeutic goals and approach with both specificity and flexibility. So someone who's been in a supportive psychotherapy with a wonderful relationship with their therapist, that is a wonderful and important thing. But for example, if they're having panic, got put on a medication for panic attacks long ago and they've never tried CBT, maybe they should try some CBT and see if we can get them off the medication. We want to involve the family or partner when it's possible and safe. And we also need to consider the family system and risk. So I have a lot of patients who kind of decide to gut it out in terms of their anxiety or depression during their first pregnancy, but then in their second pregnancy with a toddler at home and trying to balance, work-life balance, everything, they are not able to gut it out. Or they decide it's not even in the best interest of their other child, their family, or even their current pregnancy. We want to stay up to date on the literature, but with knowledge about confounders and the context, as well as the biases of the speakers and the publishers. And communication and education with patient supports and all treatment providers is an iterative process and one that's ongoing. And above all, don't panic and try not to only treat your own anxiety, which is a trap that we can all fall into. And then finally, clinicians caring for perinatal patients are in a unique position to help connect our patients to resources and motivate them for positive changes whose impacts can cross generations. Okay, so this is a lot of suggestions for things that actually would be helpful from a public health perspective, including increased screening and funding for integrated care and treatment resources, advocacy for national protection for reproductive rights, improving representation of minoritized groups in perinatal health and mental health fields, maintaining Medicaid coverage for all pregnant people through 1 year postpartum, providing coverage for culturally congruent services to perinatal people and families outside traditional medical models, enhancing access across the digital divide, providing support for high-quality childcare services for families with limited resources, enhanced data and research into models of care and increased access for perinatal mental health, and national parental leave policy. That's my plug for things would be actually helpful from a public health perspective to address maternal mental health. And then I always end this lecture with this picture of my daughter when she was first born, and she just had her 17th birthday. So this is a little old. All right. Thank you for sitting through that. And happy to answer any questions.
Thank you, Betsy.
I didn't have any questions come through on the chat just yet.
Okay. Got about 10 minutes if anyone has any questions, comments, or thoughts.
Hi, Betsy. It's your Carla. How are
Hey,
you?
you, Carla.
Thank you so much for such a great talk. I don't know. I haven't been able to join the recent rounds, but I don't know if you